At the outset, I'd like to thank AIOC and also Dr. Ajay for including me in his very popular course. It's, I think, the second or third year running, and we've always had house full. So I'll be talking about the management of cataract and diabetes, how to optimize the outcomes, the timing, technique, and the choice of IOLs. As has already been told by my previous speakers, that diabetes is increasing in India, and as we know that it is 2 to 5 times, cataract is 2 to 5 times more frequent in diabetic patients than in our non-diabetics. It also occurs more rapidly at a younger age, and at any time we'll find that at least 1/4 of all our cataract patients are diabetics. Many of them discover that they have diabetes when they come for cataract surgery. Now, in order to optimize the visual outcomes, these diabetic patients really need a special attention. Now, the indications of cataract surgery could be a patient who has an advanced cataract, who has a poor visualization of the retina, and in order to monitor the diabetes, diabetic retinopathy, to laser the patient or to manage the diabetic macular edema, we need to have a good visualization. It can be a part of the vitreoretina surgery. And it can also be, as we know, diabetic patients are more prone to glaucoma, so it could be as part of treatment for either narrow angle glaucoma or even neovascular glaucoma. So what are the main concerns? The main concerns are that there's increased chances of post-op CME. There could be a worsening of a diabetic macular edema and a progression to PDR. As we know, diabetic patients are more prone to inflammation, so inflammation can be increased after the cataract surgery. And there's also increased risk of infection, especially when patients are poorly controlled, because it's not just the fasting and PP sugar on that particular day, but it depends on how good is their HbA1c, how good is their diabetes control, both pre-operatively and post-op. So the surgery can be challenging, especially when the patient has undergone multiple intravitreal injections or has had a previous VR surgery, and it needs a special experienced hand. So we need to do a comprehensive management, taking care of the preoperative, intraoperative, and the postoperative concerns, and look out for all the comorbidities, especially the systemic morbidities, which need to be taken care of. And coming to the ocular morbidities, again, we need to do a very detailed examination of the anterior segment. It's good to have a vitreoretina surgeon by your side when you're handling these patients. So having a good metabolic control is important. And what has been said by, I think AIOS has defined that the fasting blood sugars should be less than 140 and PP should be less than 180, at least definitely less than 200. And many of these patients who have, NPDR, if they get well controlled on their metabolic control, we can see that, these patients are then better suited to undergo cataract surgery. So this is one of the patients who underwent a good metabolic control, had a very stable retina, and this kind of case is now can be taken up for cataract surgery. So preoperatively, we need to check the HbA1c, and every little bit counts. So counseling your patients to have a better control is important. Looking into the anterior segment and doing a detailed evaluation is very important, as these patients are more prone to inflammation, to ocular surface disease. They may be having iris neovascularization. If you see your patient undilated, it's important, because a dilated patient, you may miss an NVI. And there can be coexistent glaucoma. These patients do have poor pupil dilation, making the surgery more challenging. They also have poor endothelial dysfunction, and so we need to be more cautious when we do our surgery. And with the repeated intravitreal injections, many a time they have zonular instabilities. So controlling the inflammation preoperatively is important, and ideally we can start NSAIDs about a week preoperatively and continue that 4 to 8 weeks post-op. Stabilizing the ocular surface is also important, as these patients are prone to corneal hypoesthesias. They have more MGD and delayed wound healing. So these unstable tear films will also hamper your biometry and make your keratometric readings variable. So giving them lubricants, low-dose steroids, warm compress, or even advising them an IPL or LipiFlow prior to surgery is important. Looking out for NVI, as I said, is critical because it indicates that a patient in whom you cannot view the retina may be having a PDR, and such patients would require some treatment immediately after cataract surgery. So you can plan that you may like to suture the wound in such cases, because if you are planning some intervention, either laser or intravitreal injection or a VR surgery where you cannot view the retina, so you need to make sure that your wound is stable. So, coming to glaucoma, if the patient is just on a single medication, we could go ahead just for a cataract surgery. But nowadays, we see that patients who are on multiple medications, you could combine microincision glaucoma surgery along with your cataract surgery. Or if the patient is on maximal medical therapy, you may like to go for a phacotrap. So depending on how good is the control, how compliant is your patient, accordingly, you can decide whether you want to go for a combined surgery or a sequential cataract and glaucoma surgery. So the preoperative assessment is always of the posterior segment very critical, and documentation has already been specified. It's not only medico-legally important, but it's also important to counsel the patient for the future and to prognosticate the kind of visual results which are likely after cataract surgery. So any treatment that we do, ideally the posterior segment treatment should precede the anterior segment treatment, provided that the visibility is good. And also depending upon the grade of cataract, whether it's an advanced cataract or an early cortical cataract, that itself would also help us in deciding the timing of cataract surgery. If the cataract is not so advanced and you feel that the patient may require intervention for the vitreoretina earlier, you may decide to do an early cataract surgery. But however, if the patient has maculopathy or PDR, you may like to first treat the posterior segment or do a combined cataract and VR surgery. So the intraoperative management is important because these patients are challenging. They have poor pupil dilation. They have endothelial dysfunction and zonular instabilities. So we must make sure that we use a good viscoelastic. We must coat our endothelium. Make sure that you do a less traumatic phaco, and also keep in hand your pupillary expanders, iris hooks, and CTRs, because at any point these may come in need. The kind of IOL that we choose will also depend upon whether the patient is wanting to do a monofocal lens, or in this era of multifocal lenses, patients do insist many a time. But we need to again see whether they have any posterior segment involvement, in which case a multifocal lens would not be the best choice for them. Mostly we like to choose hydrophobic acrylic lenses which cause less PCO, and these cases, if they go on to VR surgery, also the silicone oil adherence is less to hydrophobic lenses. So biometry, of course, is critical, especially where the patient has already undergone an RD surgery. We need to make sure that we do an accurate biometry, and also try to avoid using AC IOLs or iris fixated lenses. So we know that even an uncomplicated phacoemulsification can be more challenging and can have more complications, more inflammation. So it's important that whenever we are dealing with these kind of patients, it should be undertaken by an experienced surgeon. So few intraoperative pearls that I would like to specify is that you may like to do the patient under peribulbar anesthesia. The rhexis should be of optimum size, as these patients can undergo capsular phimosis, and also you would like to visualize the fundus post-operatively. A good viscoelastic I've already mentioned. And in patients who've undergone multiple injections, you should be careful about the hydrodissection, because some of these patients who've undergone vitrectomy could have a posterior capsular defect. The zonules are often lax, and we should have CTR available with us. We should do a very meticulous cortical cleanup so that we avoid an early YAG capsulotomy, and the lens should definitely be in the bag. A good viscoelastic removal to avoid post-op spikes is important. And in case you plan to do a combined surgery, or if the patient needs a laser in the early post-op period, do suture your patients. So giving aggressive anti-inflammatory, good amount of lubricants, and a close follow-up with your retina consultant in the post-op period is important. So my take-home message is that even with diabetic patients, we can have excellent results if we take a well-controlled diabetes, stable retinopathy, and if we manage the preoperative morbidities well. So early surgery is good before the patient develops any posterior segment involvement, and in case the patient is having any posterior segment, has diabetic retinopathy, we need to counsel the patients that the treatment does not end with cataract surgery. The patient must come for regular follow-up. Thank you very much.
Thanks, Dr. Ritu.